Thank you. Well, welcome everyone, and thank you for attending. We will get going since I know time is on the clock here. We're here to share about talking about with Islamic families about pasteurized donor human milk. And there are several presenters here, and I will just forward this, and we will begin. Your learning objectives are listed here, and we will progress and on with that. Here to share about the focus and the study that was done, the development of a collaboration leading to the fatwa, and then the resources that are available and ways to share this information with Muslim families. So.
And before Marcia begins, I just wanted to say thank you everybody for joining us. This is a wonderful presentation filled with information that you could utilize in your practice. We're hoping to kind of speed it up so we can give you time for Q&A. And to start us off is Marcia McCoy, who is substituting today for her partner Munira, who's unfortunately unable to join us.
So if you can do the next slide, Linda. Yes, I work for the Minnesota Department of Health WIC program, and I also provide technical assistance and research support to the Minnesota Breastfeeding Coalition. One of the things that we do is try to work with community partners on research projects. And in 2022, the MBC did their 8th annual infant feeding practices survey for hospitals. But because we had a couple of Title V students for the summer, we also decided to do some in-depth interviews with providers. So these providers in the summer of 2022 talked to us about lots of things related to breastfeeding in the hospital and specifically about donor milk. So what we found out from that is that a lot of providers themselves aren't educated on donor milk, don't understand the safety, the extensive processing that happens to make sure that the milk is safe, that there is a standardized amount of calories per ounce in the milk, and that's labeled. And then they also talked about patients not given enough information to make an informed decision. So if the provider doesn't understand donor milk well, or if the family has not been educated on the importance of human milk as opposed to formula, then they may be offered donor milk, but they're not comfortable accepting it. So next slide. And also Muslim families in particular are concerned about kinship. So the providers talked about that often Muslim families aren't even offered donor milk because the provider's experience is that the Muslim families typically won't accept it. And they don't know enough about how to talk to Muslim families about it in order to help them to make that decision in an informed way. And then also Muslim and non-Muslim families are both concerned about the safety of the milk. Could it be contaminated? Could it contain diseases that could be passed to the baby? People often have these concerns. So in this past year in 2023, we acquired a little bit more funding so that we could talk, instead of talking to providers, we could talk directly to parents themselves. Linda. Next slide. So some focus groups were conducted in September of last year with 28 Somali and 8 multi-generational Black American mothers in the metro area and in St. Cloud. These were all, and I refer to them as mothers because they self-identified as mothers. We didn't have any other gender identities in this study. We also included a survey that included some PRAMS questions about breastfeeding related hospital care, which is related to the 10 steps to see if people were getting optimal care for breastfeeding success. And also we asked them about feelings of perceived discrimination during their care. And then one goal of this study was finding out about knowledge and perceptions of donor milk. In our conference this fall, we'll be providing some more results from this study. But for now, we're going to talk about what did we learn about donor milk. So next slide. What they found was that only 2 participants were offered donor milk, and they were both African-American moms, and one of them accepted it. And this person was really grateful. It sounded like she was given some education about the importance of donor milk, and she was grateful for it. Somali participants, none of them were offered donor milk, but they also almost universally said that they believed it was not acceptable. But they also had a lot of misconceptions about donor milk, both sets of participants. Typically hadn't heard much about it, didn't understand the difference between that and informal milk sharing, had a lot of concerns about safety and in addition to the religious concerns. And just about this time in sort of a coincidence of things coming together, this research got together with the concerns that neonatologists were happening, and Shukri is going to talk a little bit more about the collaboration that came out of this.
Thank you, Marcia. And next, we're just going to go over some of the things that we offered our scholars and our groups that met in the creation of the fatwa. We have Dr. Nancy Fahim starting with the disparities and all the information that she was able to share in that meeting.
Thank you, Shukri. So my name is Nancy Fahim. I'm a neonatologist at the University of Minnesota in Health. And like Marcia and Shukri touched on very nicely, we were seeing clinically the same thing. We noticed there was hesitancy in our Minnesota Muslim community, the Somali community particularly, in using pasteurized donor human milk, even when it was advised in the NICU for very premature, vulnerable, and ill babies. And part of that was our understanding of religious concerns about milk kinship, which means that if a mom nurses another child, that child is like a milk baby for her and could be considered a sibling for her own children. And that was a large part of it, in addition to the questions about the safety of the donor milk. So we had heard about other fatwas or religious rulings in Europe several years before, and we helped arrange a coalition with the Minnesota Breastfeeding Coalition and Brighter Health Minnesota. We arranged a multidisciplinary group with healthcare leaders and Islamic scholars, because we could address the medical necessity, but we were not able to address the barriers or the understanding and the religious needs of these families. So we met together on October 5th with a large group, including neonatologists from different health facilities. And it was a great collaboration between facilities across the board. Nurse practitioners, nurses, the Milk Bank, MBC, Brighter Horizon, and next slide, please, Linda. Our goal was to meet in a round table and increase the familiarity of the local Muslim leaders about why donor milk is necessary, and I'm going to address that in the next few slides, and both medically and for equity, and also explain what the process of human milk banking is, how it's the safety of it, how it is pooled, and address any questions that come up with the imams and the scholars, and hear their views on that as well, and direct any questions or concerns related to the kinship and safety. Okay, next, please. So the next few slides, I'm just going to set a quick reminder of why we are prioritizing human milk. Again, probably heard I'm preaching to the choir, but the value of human milk is so much more than just nutrition. It is the optimal nutrition. It's from humans to humans, and especially in the vulnerable newborn, it is the best quality of milk, but it's much more than that. It's a source of protection. It has unparalleled immunomodulation, anti-infection, and anti-inflammatory properties that will affect the child their whole life. So it's actually the non-nutritional components that are becoming increasingly important as we recognize that the immunoglobulins, lactoferrin, lysozymes, oligosaccharides. So in addition to all of the well-known health benefits of human milk for any baby, in preterm infants, it's particularly important. And this is, I'm talking specifically about maternal milk, mainly decreasing sepsis because of its anti-infectious properties, and decreasing necrotizing enterocolitis. those that are familiar with the NICU know what the necrotizing enterocolitis is, but I will address that further in the next slide. But more importantly, also that mom's milk offered in the NICU has improved neurodevelopmental outcomes. It's actually measured how many mils per kilo of mom's milk in the NICU correlates with improved IQ scores later on in life. Next slide, please. So what is necrotizing enterocolitis, or NEC, which is one of the most important things we want to protect the infant against in the NICU? And I do apologize about showing these images, but I think it's really important for those that are not practicing clinically to realize what we're dealing with. So NEC, it's one of the most common and most devastating gastrointestinal emergencies in the premature infant. There's an intense inflammation and necrosis of the gut and throughout the whole body. It happens up to about 10 or 12% of low birth weight and very low birth weight infant. So it's a pretty high number if you have treating 100 babies, that 5 or 10 of them would get this horrible disease. And it's very fatal. So up to 30 to 50% of these infants will not survive. And those that do survive have long-term morbidities, including resection of the gut, so short gut, long-term TPN, and significant inflammation in the brain, and really horrible neurodevelopmental outcomes. So it is something that we want to prevent. And the one thing that we know that can help is human milk or maternal breast milk. Next slide, please. But additionally to that, we realize that pasteurized donor human milk, if mom's milk is not available, is as protective against NEC. So the one thing we come out with, and that's what we told the scholars, is that it reduces the incidence of necrotizing enterocolitis in preterm infants by more than 50%. And there's several databases, or blinded studies looking at more than 500 to 900 infants, showing a significant improvement, a reduction in the rate of NEC when you're using human milk, either mom's milk or human donor milk when mom's milk is not available. Additionally, there's improved feeding tolerance and decreased TPN days. That neurodevelopmental benefit that we see with mom's milk, we do not see that with donor milk. So it does help protect against infection, but that unique property of maternal milk to improve brain development and IQ, that is specific for mom's milk. So one of the things that we're going to touch on is not only are we supporting the use of donor milk, but we're really supporting the mom to produce her own milk during those difficult days when the baby's in the NICU. And additionally, the other important thing about donor milk is that we realize there's increased exclusive breastfeeding rates when these babies are offered an exclusive human milk diet in the NICU. That's one of the pictures I'd like to share on the side, is a mom that did have a child in the NICU. Initially was struggling to produce enough milk, but was very appreciative to being offered donor milk. And then over the next few weeks and months, she was able to produce and pay it forward by donating her own milk. Next slide, please. The other thing is the equity. Again, what we were seeing from the focus study, we were seeing it clinically, that there is a disparity in who was offered donor milk. It depended on the color of your skin, where you're from, the language you're speaking, the zip code that you're from, the hospital that you're born in. So again, sometimes unintentionally, there was some biases that who was offered donor milk in the hospitals, or which hospitals could afford to pay for it. So this is a nice chart that was Marcia had shared with us from the Minnesota Department of Health, showing among WIC infants who received most formula during their hospital stay in 2018. And we can see there's a disparity there, where East African and Hmong including East African, including Somali patients and Hmong, were the highest offered formula. and the white population being the least offered formula. And it adversely affected the breastfeeding rate. So on the contrary, the breastfeeding rate was highest in the white population where they received less formula supplementation. So again, having that pasteurized human milk helps saves lives in the NICU and helps improve equity. And that is one of what we presented to the Islamic scholars. And next slide, please. So in summary, human milk is the single most powerful intervention to optimize baby's health. And the scholars were very happy to hear that. And again, mother's milk is always preferable, and we'll address some of these issues later on. And when mom's milk is not available, then pasteurized human milk improves outcomes, improves breastfeeding rates, and improves survival. And the next step we talked about is how the understanding of how donor milk is achieved, the safety of it, the pooling, and Linda will take over to go over that.
Thank you, Nancy. I'm Linda Deck. I'm the executive director here at the Minnesota Milk Bank for Babies. We're a nonprofit located in Roseville, Minnesota. We are a member of the Human Milk Banking Association of North America, and we're licensed by the Minnesota Department of Agriculture as a food manufacturer. So after hearing the importance of human milk and pasteurized donor milk for NICU babies from Dr. Fahim, to the Muslim scholars and imams, I addressed how donor milk was processed and shared about the safety and quality measures taken to protect these vulnerable infants. The summary I gave them, it involves extra milk. Moms calling us and sharing us with their desire to share their extra milk with the milk bank. There is a screening process similar to the screening when giving blood. Plus, there are more questions regarding health, their lifestyle, what medications they take, what herbs, what supplements, etc. There's also a blood test for 5 communicable diseases, including HIV, HTLV, hepatitis B, hepatitis C, and syphilis. So the donor takes this these blood tests, and if they pass the screening and the blood test, then the donor is approved to be a milk donor by a licensed provider. And after that, arrangements are made to drop off her milk at one of our collection sites or depots around the state that we have. The next part involved sharing about how multiple donors are selected for a pool, which is then thawed and then combined in our milk lab into these pots. The reason for pooling is that milk can vary in its nutrient content greatly, anywhere from 15 to 30 calories an ounce. By pooling with multiple donors, and we have at least 3, but we try to aim for 5 or more other donors, it decreases this variability that we see in nutrient content and standardizes that as well. And then it increases also the anti-infective properties that human milk is known for. So the milk is pooled and then mixed into these large pots, and then after that, it is bottled and then sealed. Once that happens, then comes the process for pasteurization. And as you know, pasteurization is a form of food preservation. It increases the shelf life of food. We see it all the time in other items in the grocery store. So the milk is then heated by Holder pasteurization for 30 minutes to eliminate any bacteria and viruses in the milk. After that, then it is rapidly cooled in an ice bath and then labeled and then frozen and placed in our walk-in freezers. A sample from every batch is selected at random and sent to an external lab for testing. And they test for any bacterial growth that might occur. So what we want to see is actually this. So if it tests negative for growth, then we get the results back in 2 days, and then we go through a final approval process for the milk to be dispensed. So who gets our milk bank's donor milk? Well, to be a member of and accredited by Himbana, our standards are to prioritize babies in the NICUs, special care nurseries, and other inpatient units. So about 70 to 75% of our donor milk goes to these inpatient units, and the remaining 25 to 30% go to outpatient families who have usually healthy babies. So after sharing about the importance of donor milk and the safety measures during the processing, we had conducted this discussion with the scholars and imams. So next, Shukri will share about the discussion and the results.
Thank you, Linda. And just going back to the goal that we initially had in our big multidisciplinary experts meeting was to understand more what the barriers were that we were seeing in the hospital setting, in the clinical setting, and also in the community, and then gaining some more expertise from our Islamic scholars. Our goal initially, like Dr. Fahim said, was to help remove the barriers for our neonates who are vulnerable in the NICU. But when our team members met with the Islamic scholars, they really had a wonderful discussion with us and then took that to a larger group of Islamic scholars. And the conversation actually continued for days with the bigger group of scholars here in the Twin Cities that were from diverse areas. And in return, they came back to us with a ruling, the ruling which is now known as the Islamic Fatwa for Pasteurized Donor Human Milk, came about with the group of scholars who met together, went through the Quran and other Islamic literature, and really came back with this ruling that said not only was donor breast milk permissible for our vulnerable infants in the NICU, but it was permissible for all infants who could benefit from it, especially if their mother's own milk was unavailable. This, of course, was a monumental clarification, something that we hadn't seen in the United States. So we wanted to strategically present this to community, present this to other hospitals, providers, and advocates such as yourselves. And we went about that by doing a media blitz, or I could say a press conference that you guys might have seen, which is next. You can go next. In this wonderful signing in front of our local media, in other health organizations, including the U of M NICU team and our Children's Minnesota NICU team, coming together to present the fatwa that was written and really well thought out by the Islamic scholars. This fatwa is alive in different sites right now that we will share with you by the end of this webinar, but you can definitely read through it because it does have information of how they came to this conclusion for the clarification for the fatwa. And another good side effect of it, if you can go next, Linda, sorry, is not only were people really talking about the fatwa and trying to understand and eliciting conversation on the importance of donor breast milk for all babies, but it also encouraged moms to breastfeed. And to speak more specifically, our Somali community moms were now seeing more interest and more information seeking in how they could be better at breastfeeding and increase that rate and moving that dial, which was, you know, a really good goal for us, but a nice side effect for us to have breastfeeding numbers and breastfeeding rates increase in the community. Next. So during this entire time, we also, as a coalition of advocates, community members, Islamic scholars, our doctors present, made the commitment that not only were we going to share this information with all healthcare providers and communities, we were going to make it easier for you to share that and to understand what the fatwa it was about. So we created these videos in 3 different languages, which were developed by the MBC team, the Milk Bank team, our neonatologists from U of M and Children's, and they are available for any one of you guys to use. It is in Spanish, it's in Somali, Arab, and English, and it covers not only the fatwa in detail from the scholars that were present, but it also covers the reasoning of what we shared with you all today of why this is important and this is a good work for us to continue doing. Next, I will share with you the other resources that were created, which Linda will go into more detail about, which is really more available to all of you and where you can find it. Thanks, Linda.
Yeah, thank you. So besides the videos, and that was their recommendations, that it's a spoken language culture, how to best get this information out to the Muslim community. But we also wanted to share this information with the healthcare community, provider community. So having a patient education pamphlet or page to share was developed, and that it was a partnership with mHealth Fairview and Brighter Health and Children's, and everybody provided input. It was written in simplified language, and also we wanted to make this available to the public domain. Part of it was that there's information like this that exists already from other countries. We tried to approach and use there and ask them if we could modify it. But because it was proprietary, that wasn't the case. So we needed to develop our own. And in doing so, we thought, okay, well, we'd like to do something where it can remain in the public domain and share it amongst different facilities without having to go through all this again. So when this material was developed, it was designed so that it can be downloaded, printed, and shared. And each facility could, if they wanted to, place their own logo on it. We ask that they don't alter the content, but that they and use it for non-commercial purposes. However, they're free to use it. So it is available on the website, and there will be a Somali and Arabic translation available soon. The handout on the backside has QR codes to the videos and to the milk bank information. So where you can find all of this is on the Minnesota Milk Bank website. There is a page under resources that links to the fatwa information. And so the videos are there, the handout to download. There's frequently asked questions. They're available to read, and if you click on it, it'll expand with the answers there. When you get the handout here after this webinar, the links on the slides will be live, so it can take you right to these resources, that page. So next, Marshall will share a little bit more about the findings from the focus group study.
Yes, thank you, Linda. So this is just a little bit about more generally some of the things we learned about what they felt were unmet needs in this group of mothers. And first up that came was the need for more prenatal education. We asked specifically if people felt comfortable asking their healthcare provider while they were pregnant about breastfeeding. And the majority said they did not feel comfortable bringing up the topic. So it really highlights that for providers, it's important to start those education topics with their clients during pregnancy and not wait, just, not to say, well, if they're interested, they'll ask me. It's also worth thinking about going beyond the basic breast is best discussion and really to talk about the real differences between breast milk and formula, and also maybe even to touch on a little bit on donor milk, just so that people are aware that it is something that not only exists, but is acceptable and considered good practice by the medical community when it's needed. Because we really did find that people were very confused about what donor milk was and didn't have much education. And especially if you're working with populations such as the Black community or the Somali community, where you have a pretty high risk of preterm birth, the chances are the people you're working with, quite a few of them are going to end up with a baby that ends up in the NICU or needs some kind of special care. And so having these conversations before the baby is born so that they at least have a little bit of familiarity is much easier than trying to educate in the high stress situation of a baby that's gone into the NICU. There's also a real emphasis on a need for more education and guidance on both milk supply and on pumps. especially again, like in the NICU setting, we heard a lot from people that they were given pumps, but that a lot of times they didn't know how to use one. They weren't educated on how to operate them. When they got home, they didn't have a resource to call for their questions about how to handle a pump. So there's a need for that. And then language in this population was really a big barrier because a lot of the moms that participate in the focus groups had little or no English. And we heard a lot of anecdotes of interpreters not being the most skilled translators, that it made it difficult to get information. And then sometimes they even said things like, oh, the interpreter was biased and told me about the free formula I can get. Next slide, please. And then there was also definitely a need for more breastfeeding support postpartum. A lot of people talked about having good support in the hospital during the birth process, but then once the baby was born, they felt like they weren't getting support for the breastfeeding afterwards. And also there was a desire to have providers who look like me or who can speak the language. This was repeated over and over in the focus groups. And of course, that's not something that we can fix in a day, but it's definitely long-term something that we need to be focused on providing more culturally congruent care and more options for people whose English is not their first language. So next slide. So I'm turning it back over now to Shukri to talk a little bit more about how to talk to Muslim families specifically.
Thank you, Barsha. And I'm sure this is probably one of the reasons most of you have logged in, just to understand how do we talk to families of Islamic background, Muslim families, about the donor breast milk. But honestly, in doing the research and the work that we did throughout this journey of the fatwa, as well as our lactation journey, we realized breastfeeding conversations and donor breast milk conversations were very similar. There's a few key things that you do that would be really the same for both, whether you're trying to encourage a family to breastfeed or you're encouraging a family to utilize donor human milk. One of those is that cultural sensitivity, as Marsha was talking about, culturally congruent care. Understanding that is how your language would impact how families are perceiving the donor breast milk, how they're perceiving breastfeeding, knowing which topics are more sensitive to different cultures is really helpful, especially if you don't have diversity in your care team, if you don't have the ability to learn from other people in that community. Talking to those families about what's important to them, learning from those families what is a deal breaker and what is a barrier for them is really essential. And we encourage that as lifelong learners, whether you're doing this work in the community as a lactation advocate or in a hospital setting, that you do learn from the communities that you serve. And that brings me to that third point, which is understanding your patient profile. In this webinar, we've used Muslim families, Islamic families, Somalis, but mainly, I want to point out that those are all different aspects of our patient profiles. We are mentioning Somali families because that's the largest Muslim community here in Minnesota. But this fatwa is not a Somali fatwa. It is not just for the Somali community. It is definitely a Muslim Islamic fatwa for anybody that's practicing. And that might be our, Somali immigrants, it might be Arabic immigrants, it might be other immigrants from Mexico who are Muslim as well as American-born Black Muslims, American-born African-American, non-Hispanic Muslims as well. So understanding that there is a different aspect in culture and religion. And when you're offering resources, you're not blatantly making an assumption in how that community perceives this information, and really knowing that there's a difference is something that I wanted to point out. The other thing that we learned throughout this process is not only to be kind, but also to be inquisitive. I think in my many years as a lactation advocate and a labor and delivery nurse, we've done a lot of work in understanding, okay, what our families are saying and what we need to help them with. And for the most part, we've lost that inquisition part because we wanted to be respectful and we wanted families to not feel like their cultural, religious background was being invaded on. So we never really dug deep into what those barriers were. with this fatwa, we learned the community, the patients that we serve wanted us to ask more questions. They really wanted us to inquire about the barriers, and that way we could seek resources from the experts. In no way are we as healthcare providers Islamic experts. The Islamic experts were not medical experts. So that bringing together of the two big groups and then the community in was a big factor for us to learn from one another and to understand, how we could work together to relieve this barrier of religion when it came to donor breast milk. Now, since October, November, we had the press conference and been in practice with families and hospitals utilizing the fatwa. We are hearing questions. We're always answering frequent asked questions. And as Linda pointed out, we have those frequent asked questions out there for you all to read through and for also to share with your patients who have similar questions. The answers from the Islamic experts, answers from our doctors who are here, from our lactation experts, and from the community. But if you are interested in developing a script, I always say utilizing something like what I just drafted here, where you're talking about what you know and giving the families resources that were provided to you. So you're not the expert of the fatwa. In no way would we expect even myself to go out and explain to a family how the fatwa came to be and what the different topics the scholars discussed were. But giving the families that information and having them hear it right from the scholars is what we recommend, and using the same language as to my expertise lie in this. I'm a lactation advocate. I'm a medical expert. This is where I'm able to help you with. And then finally, the biggest thing that families are telling us and we are all seeing is listening to the concerns of the families and directing them to what they need. Some families might need to talk about safety. Some families might need to learn more about how we pasteurize this donor breast milk or how it comes to be donated. Some families want to know more about what their babies with formula what are some outcomes or health outcomes when babies use formula versus donor breast milk, but finding the right resources for those families. And that comes from listening to the families. And that is, I think, the last one that we have before we have questions. Always feel free to email any of us here too, if you have any specific questions.
Hi, this is Chip. I came on late, but I got the last 20 minutes of that. That was fantastic. One thing I really like is how you said that families actually want us to ask them questions. They want us to lean into their faith and understand exactly where they are and what is their reticence to breastfeed. So I will definitely do that in the NICU. The question I had was, and maybe this was addressed early in this presentation, is there a cultural reticence amongst Muslims or those of the Islamic faith to not breastfeed? Is there something in the culture that says a woman should not bare her breasts and breastfeed a baby, or is that not true? Or is there anything that makes that something that shouldn't happen in the first few months? It seems like moms are often kind of sheltered away and kept warm and waited on. And it seems like even just that 30 days of them being cared for would get in the way of anybody breastfeeding successfully. So is there something culturally that we need to address as well from that perspective?
That's a really good question, Dr. Martin. I will say, myself not being an Islamic expert or a scholar, what we heard in those meetings when we met with the scholars, though, was they pointed out 6 different excerpts from the Quran and literature in the Islamic literature that they had that showcased and really highlighted the importance of breastfeeding our children in the Islamic faith. And they really talked about how that is it's something that we had to do. I wouldn't say an obligation, but it was something that was not only encouraged, but something that all mothers were told to do up to the age of 2. So I don't foresee, I think that would be contraindicated if then we have another religious or cultural rules that says we don't do it. I do believe that throughout time, maybe cultures have influenced how we take care of our babies and how we feed them. But in terms of religion, there isn't any doctrine that I'm aware of or that the scholars had shared with us that prohibits families from breastfeeding. There is the aspect of modesty, which I think might play a role in, if I'm hypothesizing, especially if there's a male doctor or a male provider in the room. It is really not a good place for us to breastfeed and have that privacy that we would need if that's what we were doing.
I'd like to reinforce what Jamali said. That I agree, because when I would round in Egypt, it's more the element of modesty. So I think just kind of being aware, making sure that we have a space that privacy won't be invaded, and just kind of like announcing ourselves, especially if it's a meal provider, is key.
Thank you, and this has been a great presentation. I'm sure there are questions that have come up. I'm Carol. I work as the 10-Step Learning Collaborative Director through the Minnesota Breastfeeding Coalition, and we've got just a few more minutes for questions, other questions you might have. And I have to say that the website for the Milk Bank has got a great resource for the FAQs and things I hadn't even thought of, like the question was asked, is genetic material of the donor's milk passed on to the child? I don't know if anyone wants to address that.
Can address that. So actually, I reached out to one of our geneticists as well, and president of the Himbana Milk Bank. So it is not because of, and it is one of the questions that is answered on the frequently asked questions, because of the pasteurization and unfolding of genetic material. So it is not a viable genetic material. And I wonder, Linda, if there is time, can you share the website and just kind of go through that?
And I
Yeah.
also will say that Kelsey Lee has a question. I don't know what it is, so she can speak up maybe after you've shared that, Linda.
Yeah, let me pull it up. Maybe you can answer your question while I'm pulling up the resource.
Yeah. Kelsey from Abbott, if you're unable to unmute, sometimes Zoom acts up. You can always type it in too.
Yep. In the meantime, there's another question from Nanette, interested from M Health Fairview, interested in advice in counseling families who are concerned about lack of milk in early days of breastfeeding.
I can take that too. I know this is something that we've really struggled with in the lactation world, trying to provide adequate education to our families before it's time to breastfeed or before you're having your baby in the hospital. In all honesty, what we're finding is, especially when we did those surveys with families, they're just unaware of the concept of, the more we have babies suckling, the more milk we produce. And reiterating that in a form and in a manner that patient understands is really useful. I found that, especially in practice when I'm talking to families, just having that language so that families understand there is work that needs to be done for you to produce milk. It's not something that just happens by all on its own and it's spontaneous. There is some work that you and baby both have to do in order for that milk to come in. That is the best thing I can think of. We're working on developing some language specific, culture specific resources for breastfeeding encouragement. But until then, I think that's the best advice I would give.
And I think to add on to that, what we found from the focus groups was that a lot of people are sent home from the hospital without any resources to turn to post discharge, and that typically for any new mother in those first couple of weeks, there's so much anxiety about milk supply that it's really important for them to have somebody they can call that's a support person. In WIC, we provide peer counselors that can help moms with that. There are other sources, but people really need to have some sort of support system post-discharge to help with that.
Yeah, I second that too. Unfortunately, one of a relative of mine, and she really wanted to breastfeed and failed. And one of those things, she was nursing for the first day for 2 minutes, and she was hearing, "Oh, good job." And then the next day said, "The baby's not breastfeeding well." And she was like totally surprised. So I think we need to do better with lactation support in all cultures, and just kind of understanding, realizing, especially with first time moms, that it's like I think the Shukri or Marcia said that it's not a natural thing. It really, what is a good latch? What are the expectations for the baby? How the milk is just not going to come pouring out the first 2 days. What is an acceptable weight loss? Just kind of guiding them, really giving more information, what the process looks like, what are the expectations, and a better understanding and support as an outpatient now that patients are being discharged earlier.
Yeah, birth is also a natural process, but we don't tell people it's natural, good luck, go do that.
Right.
And it's the same thing with lactation. They need something more than just, you need to do this because you're a better mother if you breastfeed, but we're not going to give you any help, so.
And we're not surprised with the lack of perinatal education available, especially when it comes to lactation. But what sometimes surprises me is kind of the lack of communication with patients prenatally. You'll have patients who'll come all the way to labor and delivery. They've had a mastectomy, but nobody's talked to them about lactation, and they were interested in breastfeeding. And it's things like that where we're like, I wish we could catch it before we were, in the inpatient setting, but there's definitely barriers in the amount of time that we have in the prenatal setting. The Breastfeeding Coalition, as well as the Milk Bank, always working on resources for families. So if there is anybody in the community or in your setting that is looking for information, please send them our way.
And yeah, there's research that shows that just a brief mention that breastfeeding is considered the healthiest thing for babies by the provider during pregnancy makes a huge difference in how motivated people are to breastfeed. So it doesn't take a lot of time to at least bring this topic up and perhaps point people to resources that need more information.
And Linda, it looks like you've got the website pulled up with questions, some of the questions that are there.
Yes, so this is the link to the website page and explaining, you can link to the fatwa itself at Brighter Health, Minnesota, to see the language. And then the FAQs are designed so that, when you click on them, they expand with the answer below and the recommendations and things that we have answered previously. We just added, there's another document that was just uploaded recently this morning, in fact, with additional questions that were submitted. I think after this convening happened and we started, and the press release and the media release, Brighter Health received a lot of questions.
At this point, it's over 1,000 emails that they've been trying to respond to. And these are the frequently asked questions that they are seeing in these emails.
Yeah, so UNERO worked very hard to compile or condense the general themes of these questions and put it in this PDF document. There's a combination of different themes in here, and it looks, and from what she mentioned, those that are related to the religious questions were they had consulted with an imam to provide those answers. So feel free to open this up and take a look at the additional questions and some of the information. It's great information that's here. It gets into a little bit more. It's on our website now for you to use and download, and it's made available. So as you can, what we're very glad to hear that, the Muslim family, they're very inquisitive and very they're thinking, and they wanted additional answers to their questions, and a lot of them. And so we're happy to provide what we can as resources, and hope you're able to access them and use them. Any other questions?
And you can download the handout from the website as well, from that same website. You can download the handouts from there and the videos.
Correct. Yes.
And
so the videos are here.
Do you want to just explain what is Brighter Health Minnesota?
Shukri?
Yeah.
Do you want to answer, or should I?
Yes. Brighter Health is a community advocacy team of healthcare providers. They're nurse practitioners who work on improving health literacy. They've partnered with us at Minnesota Breastfeeding Coalition, as well as with WIC and MDH, to help create resources and to help get us into the community. So they've been the bridge for us to make sure that we are culturally appropriate, religiously appropriate, and the connectors to the healthcare workers and the community for us.
Excellent.
And I did not mention it before, but they, two researchers from there, Munira and also Jamila, actually recruited and conducted the focus groups and provided the translations for those that weren't English speakers. I see a raised hand.
Yeah, I see the hand for Adepeju, but I'm not, maybe, can you?
Afternoon, everyone. It's pronounced Adepeju. It's
Thank
more, it's not a question, it's actually more of a statement. First of all, congratulations to the research, because a lot of times we don't have the information in data form to guide our policies and our actions with care. So that is wonderful. Second thing, though, I wanted to say, I have a question. You guys noted that there was an increase with lactation with mothers who received care. I thought that was interesting. I was wondering, is it that mothers, after receiving care in NICU, felt supported, felt informed, so they continue to lactate after? I think that would be an interesting extension of the research as well, because that would actually go to the proving that once women have the support necessary and feel informed and empowered, that they're more likely to lactate. And I think indirectly your research is evidence of that, because that was like very interesting.
Yeah, and I think that part of that is it points out that many of the people don't have a lot of information about the difference between human milk and formula, and that in that NICU setting where it's explained to them why we want to use donor human milk, it really emphasizes the importance of that, of human milk as being the best, and that motivates people as well.
And I will add, what we're noticing too now is families saying, so donor breast milk is this important that we are creating a clarification. We're doing a fatwa for donor breast milk. That in turn then means my breast milk is just as important, if not even more, for my babies. So I'm going to do everything that I need to do to make sure that I have enough supply, that I have enough to feed my baby. So we're seeing kind of this other impact from the fatwa, where families are wanting to breastfeed and wanting to get information on breastfeeding so that they can, you know, utilize their own supply. And that's really a positive for us.
And I think that's one of the reasons, though, that AAP guidelines or breastfeeding policy guidelines that came out in 2022 advocated for it was clear that breast milk for all very low birth weight infants, but they advocated it for the late preterm or the early term that needs supplement in the hospital. And one of the reasons specifically was that the research is showing that these parents or these patients who receive exclusive breast milk when needed do have a better breastfeeding rate, exclusive breastfeeding rate longer.
This is Chip. That is absolutely correct. If we don't provide formula to babies in the hospital at all, we have a much better rate of moms continuing using breast milk and using it longer. Absolutely, without a doubt, which is what our Amethyst Blue study is looking at: moms who express breast milk at home starting at 37 weeks. And therefore, when a baby needs supplementation in the hospital for low birth weight or for hypoglycemia, the nurse can reach for mom's breast milk that she has brought in from home, that she has expressed before the baby was born, rather than reaching for the formula on the shelf. And if we can not use that formula on the shelf in the hospital, we can, and this is what we're looking at, can we potentially decrease any formula exposure to that baby in the first 3 to 6 months of life.
Thanks, Chip. We are out of time, but I did want to call your attention to my little public service announcement there in the chat. We're having a great conference coming up in October, and actually Marcia will be going into more detail about the unmet needs and perinatal services study. Linda will give an update about the milk bank. We've got a great set of speakers balancing practical information, clinical information with information about how to better serve some underrepresented populations, which I'm sure are not only in Minnesota, but in other places. Just want to thank you all for coming. Don't forget to, you'll get an email with the link for filling out your evaluation and doing a test to see how well we met your learning objectives. And we'll take it from there. Have a great week, everyone.
Thanks so much.
Thank you.
Everyone.
You.